The ultimate question that is trying to be answered is, were the methods appropriate to the conclusion? Were the methods appropriate to reach the conclusion? So if they don't use the right methods, then I don't care what their conclusion is. Their conclusion could be that I'm the greatest person in the world. That would be correct, but if their methods are not correct, then I can't even enjoy their conclusion, which is that I'm the greatest person in the world. I'm just joking, spontaneously. But if their methods don't support the conclusion, then it doesn't matter what the conclusion is. You can't like it, even if you want to like it. So if I read an article that supports, drinking ginger ale after my workout. Let's assume for a moment that I love to work out and then drink ginger ale. It's not true, but I just made it up. If I read an article that says drinking ginger ale after working out is the best thing you could possibly do for your body, I might instinctively want to accept that conclusion because it aligns with the way that I live and the way that I do, assuming that that's what I do. But if I read the methods of a study that concluded that, and their methods are bogus, then I can't even enjoy the conclusion that I want to enjoy, because I, as a analyst, so to speak, of research, would know that the methods were bogus, and therefore they don't even have the right to have that conclusion.
I have come here to chew bubblegum and kick ass. And I'm all out of bubblegum.
What's going on, everybody? Dr. Vasquez here, coming to you live and very spontaneously right now. So I'm going to review an article with you that I've only barely looked at. I just downloaded it this morning. And I'm going to show you how I look at research. And you can care about that or not care about it. But I do have 3 doctorate degrees, and I have published a lot of research. And I have read tens of thousands of articles over the past 30 years. So some of you might consider that. Maybe I have an opinion worth listening to, but that's up to you. So I am going to show you how I look at an article like this. And I hope you're all doing well, and I hope you're all happy, because after I read this article to you, you might not be so happy. Or you may be happy. Some people like the truth, some people don't. But this is going to be a little bit shocking for some of you. So let's look at this article, which I have in front of me. And like I said, I just downloaded it this morning. I looked at it. I made an opinion on it. And I agree with my own opinion. How about that? Of course I do. But I'm going to show you why I agree with my own opinion. So this article apparently was published just this month, so it's brand new. I'm sorry, accepted on August 2nd of 2026. So this is brand new. This is published by the American Association of Clinical Endocrinology. American Association of Clinical Endocrinology. So these are mostly medical doctors and maybe some PAs and NPs and some others, but mostly medical audience specialized in endocrinology. So, some of these people they might be family medicine, but a lot of them, and family medicine is very difficult. I'm not saying family medicine is just some casual thing that people stumble into. I mean, family medicine's hard. You got to know everything family medicine includes emergency medicine, urgent care, pediatrics, gynecology, obstetrics, elder care. I mean, family medicine is a very difficult board certification to acquire. So, some of these people are probably family medicine, but a lot of them are probably internal medicine with a specialization in endocrinology. So anyway, let's look at this. Actually, maybe here's what I'll do. Maybe I'll time myself on one of my watches here. Maybe I'll time myself, and I'll show you how, if you're looking at, tens of thousands of articles in a given year, then you have to get good at it. You have to get fast at it, And so a couple of ways to do that, or a couple of aspects of doing that, is number one, when you look at a lot of research, when a person looks at a lot of research like me, I just became a research fiend when I was about 22 years old. I just started reading everything I could get, literally. And so one of the things that a person notices as they read tens of thousands of articles is that articles typically have a certain flow or cadence to them. And the importance of that is that when you see an article deviate from that flow or cadence, you know, maybe it's a really good article, maybe it's better than most articles, but a lot of times the deviation from that normal cadence is a signal that this is going to be bullshit. So that's one way, that's one thing that I think about when I look at research. Another thing that I want to say, and I have said this before, but the most important two tools that you have to have in order to critically read research is, one is you just have to be a good reader. I mean, you just have to read what they say. But as you're reading it, you have to filter it and test it, and you have to be asking yourself, does this even make sense? So logical thought tends to be linear and sequential. So one idea flows seamlessly into the other. So you have an idea here, it goes to the next idea, it goes to the next idea. That's what's famously referred to as linear thinking, and some people don't like it or they get bored with it or whatever, but that is how logic works. You connect one thing to another, and yeah, you can take some tangents, but if you do take a tangent, it has to come back to the main idea. So it should be linear and it should flow together. More than anything, it should flow. The defining principle of a logical error or a mistake in logic is called a non sequitur, which means it doesn't follow. It doesn't, A has to go to B to C to D. If you go from A to G to Z and then back to B, then that's a problem. And so, you know, again, like I said at the beginning, part of what I look for, what you should look for when you look at research, is you should look for a natural flow of events. Things should make sense in the natural progression and cadence of what they're talking about. When you see them, for example, introduce a topic, and then they go from a nice introduction to just an assumption or a leap of faith over here that doesn't make sense, especially if it doesn't have good citations to it, then you know they're deviating from their own course. So typically the introductions are usually pretty smooth. They'll say, you know, diabetes is a common problem and we need to study the complications. Okay, that obviously makes sense. But then they're going to introduce, as they did in this article, they introduce something, a radically different way to interpret lab tests, for example, or a radically deviant way to do something in clinical care that already has an established norm, you know? So if you know from your own background study that the norm should be this, and then you read an article like this one, and they're deviating from that norm, you know that they're deviating for a reason, especially if they don't explain it. Now, they could deviate from the norm, and they could say, we are doing X, Y, and Z for the following reasons that are now well established. And we appreciate that this goes contrary to popular practice, but this should be the standard of care. You know, they can say that they're deviating, and then they can justify it. If they deviate without justifying it, then you have to be aware of that. And as I started to say a minute ago, to read research, you have to have at least two tools. You have to be able to read and think at the same time, critical thinking, critical analysis, but you also have to have some background information. And the other thing that I wanted to say, and then I'll get into this, the other thing that I wanted to say that I noticed in medical school, for example, and as I've mentioned before, I did a pre-doctoral research fellowship with the NIH, the National Institutes of Health in the United States. I did a pre-doctoral research fellowship with the NIH because I knew that I wanted to do research and things like that. So I applied for the program. I got into the program in my last year of medical school. Oh, and of course we had classes on how to evaluate research because the whole purpose of the program was to conduct research. And I'm telling you now, because I've seen this play out several times now. First of all, the people who teach those classes usually aren't very good critical thinkers. And so they are obviously simply going to parrot or echo the standard way that the medical world looks at research because they're trying to get you to do the same thing that's always been done. That's called the standard of care. Standard of care in medicine has nothing to do with quality. It has to do with doing what everybody else always does. And so that same mentality permeates courses in how to look at research because those courses are taught by medical school faculty who went to medical school. And so by definition, those people are indoctrinated into the system. So they don't even know it, but they are parroting back a system that may or may not even make sense. But I'm telling you, they wouldn't have their jobs if they were independent thinkers because like me, they would either get kicked out of the system or they would kick themselves out of the system. So one of the things that they teach in research design classes and research evaluation classes is you're supposed to look at a research article like this very superficially. You're supposed to look at it, was it randomized, was it double-blind, was it placebo-controlled if it's an interventional study? The ultimate question that is trying to be answered is, were the methods appropriate to the conclusion? Were the methods appropriate to reach the conclusion? So if they don't use the right methods, then I don't care what their conclusion is. Their conclusion could be that I'm the greatest person in the world. That would be correct, but if their methods are not correct, then I can't even enjoy their conclusion, which is that I'm the greatest person in the world. I'm just joking, spontaneously. But if their methods don't support the conclusion, then it doesn't matter what the conclusion is. You can't like it, even if you want to like it. So if I read an article that supports, drinking ginger ale after my workout. Let's assume for a moment that I love to work out and then drink ginger ale. It's not true, but I just made it up. If I read an article that says drinking ginger ale after working out is the best thing you could possibly do for your body, I might instinctively want to accept that conclusion because it aligns with the way that I live and the way that I do, assuming that that's what I do. But if I read the methods of a study that concluded that, and their methods are bogus, then I can't even enjoy the conclusion that I want to enjoy, because I, as a analyst, so to speak, of research, would know that the methods were bogus, and therefore they don't even have the right to have that conclusion. So hopefully you get all that. So let's take a look at this. So I'm going to look at this. Let's just see how long it takes me to find and explain to you why I think this is bullshit, or at least suspicious. So I think this is bullshit. If I didn't think it was total bullshit, then I would at least think it's suspicious, and I'm going to show you why in just a moment. And when I show you why, you're going to freak out. You are going to freak out when I show you what's going on here. Or maybe not. Maybe you're all cynical by now because of the COVID pandemic, and maybe now your eyes have been opened to how corrupt the world is and how bogus all this philanthropy, medical, public health bullshit is. So maybe you're all aware of that now. And so maybe now nothing can surprise you. Maybe that's the case, I don't know. But if you're, happy-go-lucky person, then this is going to surprise you, because it's not going to be good. So this is all just stuff, like I said, I just looked it up this morning. I didn't really know who the American Association of Clinical Endocrinology was, so I looked up their website. I just went to their website, and they have corporate partners. Well, who do you think their corporate partners are? It's all drug companies. So do drug companies want to solve the problem of diabetes and its complications? Hell no, they don't want to solve anything. That's where they make their money. So the fact that this organization is funded by drug companies who, by definition, don't want a solution to these problems, well, that's a red flag. In this case in particular, so the title of this article is Metformin and B12 Deficiency, a Prevalence Study. So here's what you need to know in case you don't understand what's going on here. Metformin is considered the first-line treatment for type 2 diabetes. A person comes into their office, they've got whatever, usually obese, metabolically obese, if not physically obese, and the doctor says, you've got diabetes. Typically, the first drug on the first day is going to be metformin. The problem with metformin, other than the fact that it obviously doesn't solve any problems, the problem with metformin is that it causes malabsorption of vitamin B12. And when people are B12 deficient, they have increased risk for fatigue, depression, anemia, and peripheral neuropathy and dementia. So what this study is trying to look at is what is the prevalence of B12 deficiency in people at risk for B12 deficiency because they're taking the drug metformin. The most obvious complication of a metformin-induced B12 deficiency is a peripheral neuropathy, which means numbness and tingling in the hands and feet. It's very painful, but it can be reversed very easily with B12 supplementation. Do these medical organizations funded by drug companies, do these medical organizations funded by drug companies, do they want to sell drugs to everyone on the planet. Yes, they do. That's how they make their money. Do they want to sell drugs for a chronic pain problem? Hell yes, they do. That actually is a bigger market than diabetes itself. So these people are on metformin because of their diabetes. But diabetes is famously a silent disease. Nobody goes to their doctor because they have a blood sugar of 150 or 200. They don't know. So because diabetes is a silent disease, the more aggressive drug market is actually the pain, because people know if they have pain. If somebody has pain and numbness and tingling in their hands and feet, they're going to know about it and they'll go to the doctor. And maybe that's their presentation of diabetes. But it's a big drug market. And the drugs don't work and the drugs suck. And a lot of times people have to be on multiple drugs when they have peripheral neuropathy because the drugs don't work very well. So, in other words, like I said, hopefully you got it by now, diabetes is a huge market because 40% of people in the Western world are obese or overweight or diabetic. Within the population of people with diabetes, a lot of them are going to develop peripheral neuropathy. A lot of that peripheral neuropathy is due to B12 deficiency, not the diabetes. So if this were a problem, that metformin were causing a lot of B12 deficiency and therefore the neuropathy, then the easiest solution would obviously be B12 supplementation. But the drug companies don't want you to do that because they want to sell their drugs that don't work. All right, hopefully you got it by now. Time to move on. So let's look at this. Oh, yeah. Let's see. Okay, so I'm just going to go through this sequentially. I'm not doing the critical analysis part yet, so that's why I haven't started my timer. But I'm going to show you something that's going to upset some of you. Or maybe you can't be upset anymore because you're already cynical because you just saw the past 6 years since the COVID pandemic of governments and drug companies and the media and everything related to public health trying to destroy humanity. So maybe by now you're over it. But here's what I want to tell you. These organizations that are funded by this master organization, it's the same people who orchestrated your pandemic. These people are aligned with the Bill and Melinda Gates Foundation. These people are partially owned by Vanguard and BlackRock, two of the most notorious, horrid, corrupt, whatever you want, maleficent organizations, high profit organizations on the planet. I mean, you have to know that by now. And I don't even know that much about it, but I know it's bad news. So it's a medical organization funded by drug companies, but owned and managed by these philanthropist groups like the Bill and Melinda Gates Foundation. I mean, you got to be kidding. If you don't know that that's a red flag by now, then you haven't been paying attention to anything over the past 6 years. So, yeah, it's time you got to wake up, or maybe you don't. Maybe you're happy with whatever sleepy life you have. All right. So, here we go. I'm about to get into this. Let me see where I want to start. I just want to look at one thing before I totally dive into that. I just want to look at the age of the people that they included in this. Yeah, average age was 54 years. Okay, so let's look at it. So remember what I said. I've looked at and read tens of thousands of articles. I know what to look for. I know how to critically read stuff. I know the cadence I expect. And I have enough background information to evaluate what they say. Whereas a lot of docs in family medicine practice or internal medicine, maybe they wouldn't have so much background in nutrition because they don't read nutrition articles. So I'm gonna show you how fast and easy this is. All right, so here we go. So let's assume that I want to form an opinion on this to know if it's even worth reading. Like, let's say I'm writing a book or a chapter on this topic, and I want to know if I should include this or if this is just a waste of time. So let's look at what they say here in the abstract. Like I said, these are diabetic patients taking metformin, and the researchers here are looking for the prevalence of B12 deficiency. So the obvious question is, well, how did they define B12 deficiency? And they state it right here. B12 deficiency was defined by a plasma B12 less than or equal to 250 picomoles per liter. Okay, so that's the definition of B12 deficiency in this article. Is that definition correct? Hell no. So they're using a cutoff of 250. It should be 600. So the way that they didn't find B12 deficiency in their population is they just defined it so narrowly that no one would have B12 deficiency. I mean, this is absurd. Plus, this test is notoriously inaccurate. So it's the wrong test, but it's also the wrong interpretation of the wrong test. So look at that. I'm only a minute and 30 seconds into this, and this whole thing is already blown out of the water. Like, this is bogus, but it gets worse. So what they say here is they defined B12 deficiency. Watch this. B12 deficiency was defined by a plasma B12 less than 250 and elevated serum methylmalonic acid. That's also bogus because it should be or, not and. So either one, you don't need to have both tests positive to make the diagnosis here. Either one. So they said and they should have said or. And that's a huge difference. If you're trying to, in the world of laboratory testing, this would be called conjugate seropositivity, which means you have to have two lab tests positive to make the diagnosis. That's not how this works. It should be either or, not both. And that's what I'm telling you now, I believe was published back in 1994 in the American Journal of Clinical Nutrition. So I'm reasonably guessing that what they're declaring here as their standard is 30 years out of date. I believe it was in the mid-1990s. I think it was 1994, could have been 1996. So either way you look at it, it's 30 years old. So they're using the wrong test with the wrong interpretation, and they're stating here that they required conjugate seropositivity, and that's not the diagnostic criteria. So that's the wrong criteria. But it gets worse. They're trying to conclude that the nutritional deficiency isn't a problem because the people funding this organization are the people selling drugs for the problem. So let's look at this in their methods, the section on their methods. So again, they used a cutoff of 250. The correct cutoff is 600. MMA, methylmalonic acid, is also a marker of intracellular B12 depletion. That's correct, but can also be elevated in cases of impaired renal function. So after they tested for B12, then they tested for methylmalonic acid. But if their kidney function was decreased, which is what you would expect in elderly diabetic patients, then they excluded those people from the study, from the results, so to speak. So you see how they filtered these people 3 times. They used the wrong test with the wrong criteria. That was one filter. Then they measured methylmalonic acid, but then they excluded those people if they had impaired renal function. So they filtered these people 4 times, I'm going to say. So obviously they're not going to find the problem because they excluded it. You know, they had 4 different exclusion criteria in sequence. So a person would have to pass all of those 3 bogus tests in order to be diagnosed with B12 deficiency, and it's still not right. So if the MMA level exceeds the age-specific upper reference limit and the estimated EGFR, glomerular, sorry, I haven't eaten all day because I'm fasting today, but glomerular filtration rate is greater than 60, the findings do warrant. So if the kidney function is okay, then these people probably have B12 deficiency. If the MMA is elevated and the EGFR is low, then these people have renal insufficiency and it's deemed inconclusive. So let's see what else they did. No. But look at what they do here. Look at what they do here. They say the findings suggest a likely B12 deficiency warranting further clinical assessment. So they're not even willing to give the diagnosis after someone has met their criteria. So what would be the further clinical assessment? So they have other criteria. Sorry, so I've been looking at this now for 8 minutes, 7 minutes. For patients identified, this is the end of their methods section. For patients identified with biochemical B12 deficiency, further information was collected by reviewing electronic medical records. Symptoms of B12 deficiency: lower extremity numbness and tingling called paresthesia, anemia, with other causes of B12 deficiency. Yeah, so, I mean, this is just bogus. So, back in 2005, so that's 21 years ago, Lawrence Solomon published in a major hematology journal called Blood, he published a review article looking at the clinical utility of vitamin B12, homocysteine, and methylmalonic acid. His conclusion was that none of those tests were accurate, and that 100% accurate, let's say, and that the appropriate assessment of B12 deficiency could be to do those tests. You could do a B12, you could do a homocysteine, you could do a methylmalonic acid, but if you still think they're deficient, the proper course of action is to actually do a clinical trial in which your therapeutic intervention becomes a diagnostic test in itself. So if you had patients with neuropathy and you gave them B12 and they got better, that would be the other way to diagnose a B12 deficiency. It's a clinical assessment. I don't see that they did that here. So maybe they did, but they should have. So what the appropriate thing to do here is sure, they could have done a B12, but with a cutoff of 600, not 250. Then they could have looked at methylmalonic acid. And if a question existed with a elevated methylmalonic acid and a reduced kidney function, the next appropriate step is to give those patients B12 and see if they respond. But you'll notice that they kept the clinical assessment, they kept that very vague. They kept that kind of on the periphery. It's like, oh yeah, we looked at their records, but we didn't really see anything. And so, if I'm correct in my critique of this, then you would expect them to basically find no problems, because that's apparently what they're trying to do. They're trying to not find a problem. And they even state that here. The prevalence of vitamin B12 deficiency was much lower in this study than previously reported in other groups, by other groups. Yeah, but it's because they didn't want to find it. So yeah, I think this is bogus. They tried to not find evidence of B12 deficiency so that these patients would remain untreated, so they would remain drug dependent, and that would make the sponsors of this organization, that would make them happy. Who are the sponsors of this organization that published this? Drug companies and venture capitalists, shady organizations like BlackRock and Vanguard, and the Bill and Melinda Gates Foundation. I mean, come on. So I don't see that they actually gave these people B12. They could have done that orally, or they could have done that by injection. Probably by injection is a little bit better. Just because it's more guaranteed. I mean, if you give somebody a B12 injection, you don't have to worry about compliance because, boom, they got it. But I don't see that they did that. Results. Yeah. I just don't see that they gave them. Let's see. So they do report something in Table 2. It says, among individuals receiving B12 supplementation, the association was attenuated. It's still kind of vague. I mean, association was attenuated? Remember what I said earlier? Like, if they're not talking in clear language, then that's suspect. I mean, I wouldn't say to someone if I were teaching a class on this, or if I were talking to a patient or talking to a colleague, I wouldn't say, oh, well, the association was attenuated. What the hell does that mean? So yeah, some of these people were already taking B12 supplements. Yeah. So, in categorizing research in terms of quality or garbage, this is garbage. They used the wrong test with the wrong interpretation, and then they followed it up with the more or less the correct test, but then they excluded people who had a positive test by looking at another test. So the only way that someone in this study could be diagnosed with B12 deficiency by their standards would be to have 3 tests in a row, all perfect. So remember what I said, in the world of laboratory interpretation, if we need 2 tests to reach a diagnosis, which is hardly ever the case, usually 1 test does the job. But if we're gonna have to confirm our suspicion and our lab findings with another test, that's called conjugate positivity. You have to have 2 positives. And that, like I said, that typically doesn't exist, but it does in some cases. But in this case, they would have had to have a positive B12, a positive MMA, and then perfect renal function as well. So that's like triplicate conjugate seropositivity. You would have to have 3 blood tests correct or positive in the same direction. Without, again, because they didn't want to find it, they didn't include a lot of clinical data here because they didn't want to have to clinically assess these people, because one of the ways that we clinically assess people is with a clinical trial. Like if you have a patient who you think has a sinus infection, like maybe it was allergy, maybe you thought it was a virus, maybe you think it's a bacterial infection, but they're not better after 2 weeks, then, a reasonable thing to do is you give them an antibiotic and see if they get better. That's called a clinical trial, or, a therapeutic trial. In which case, part of the therapeutic intervention becomes part of your clinical assessment. So your therapeutic intervention becomes a diagnostic trial. Your therapeutic trial becomes a diagnostic trial. And they could have done that here, but they didn't do it. They could have identified people with neuropathy or depression or fatigue, and they could have said, look, we're going to give you B12 high dose for 3 months and see if you get better. But they didn't do that. And the reason they didn't do that is because they didn't want people thinking clinically, and they didn't want people using nutrients, B12. This is how the medical machine works to keep people stuck on medications and stuck with their disease. And chronic pain is a perfect example. Migraine, cluster headache, fibromyalgia, peripheral neuropathy, complex regional pain syndrome, these are great examples. So here's what they wanted to conclude. They wanted to conclude the observed prevalence, which is remarkably low, and they even admit that it's remarkably low, represents the prevalence of B12 deficiency encountered in contemporary real-world diabetes care. Again, they found a very low prevalence of B12 deficiency in their study groups. They even acknowledge and admit that their findings are unusual, but that didn't stop them from publishing 18 pages of bullshit, which is basically what they did. Oh, it's 26 pages, sorry. 26 pages. But again, that's part of how That's part of the medical paradigm. They can do stuff that is so stupid, they even know it's wrong. They even know, hey, something's not right here. They even admit that something's not right about their findings, or that their findings are different from what was found by other groups. They even admit it here. But they don't admit it to the point where they actually stop and say, hey, maybe we did something wrong. Yeah, I mean, this is just total stupid. So look at their flow chart here. This is the last thing I'll talk about. So this is what they want to find. They want to conclude that B12 deficiency is unlikely. So this doorway was wide open. They want their patients to not have B12 deficiency. That's the conclusion that they want. So you could have a low number here, but then you would have to have perfect numbers here in order to maybe be diagnosed with B12 deficiency. And you'll see what they should have done here. If the patient had a high methylmalonic acid and their kidney function was reduced, they write and they concluded that the results are inconclusive. But what they should have done in that group is look for signs and symptoms and then use a therapeutic trial, which would have then given diagnostic information. And that's exactly where they went wrong on this. So anyway, that's my review of this. But this is bad research that leads to bad clinical care. But they designed the study to reach the conclusion that they wanted to reach, and that is that nutrition doesn't matter, supplements are not necessary, the drug isn't causing problems, and these patients should stay on neuropathic drugs, which are horrible. They are, as a group, the neuropathic drugs are probably the least effective drugs on the market for the money. They're expensive, sometimes they're addictive, sometimes they make the pain worse, they've got a lot of side effects. But the nutritional solution is what is being kept from this audience by research like this. That's designed to not find a nutritional problem, so the only solution available is to keep these people on drugs. That's all I'm going to say about this. Hope you're all doing well. Take care. This has been Dr. Vasquez coming to you live. Hope you're all doing well. Bye-bye.